Yes, so circulating tumor cells in multiple myeloma is an up-and-coming biomarker, and a biomarker that I am very excited about personally because it can be obtained just from a blood draw. We don't need to do a bone marrow biopsy. One of the problems with many studies that have been done on circulating tumor cells is most of them were retrospective and the treatment was very heterogeneous, so we could not make firm conclusions. But data from Mayo Clinic in the past have clearly shown that patients who have positive circulating plasma cells after treatment or a high burden of circulating plasma cells at diagnosis or at relapse, they clearly have worse outcomes compared to those with a low burden or no circulating plasma cells. And this was independent of FISH cytogenetics, so it was independent of the currently used risk stratification methods that we have in multiple myeloma. Now recently, two large studies, one from Spain and one from Italy, were published in JCO as were published together actually, and they clearly showed in a prospective manner, in both of these clinical trials, circulating tumor cells was measured as a correlative assay, and both of them clearly showed that a higher burden of circulating tumor cells at diagnosis was associated with worse PFS and overall survival. Actually, I think in these two studies they mostly showed a worse PFS signal. I think the follow-up is still not enough for overall survival, but clearly there was a trend. And they also showed that this was independent of the currently used staging systems, for example, the International Staging System or the R-ISS. And when they added circulating tumor cell to the currently used staging systems, for example, R-ISS, that clearly improved the discrimination of these staging systems. So one of the challenges is that both of these studies, they use different sensitivities or different flow cytometry methodologies for assessing circulating tumor cells, and because of that, the cutoffs they reached at was slightly different. So we clearly need harmonized cutoff that can be easily applied to community hospitals, for example, or places where most myeloma patients are treated, and also additional methods that, for example, maybe next generation sequencing or PCR assay looking at either the immunoglobulin VDJ sequences and looking at circulating tumor cells that way, or looking at circulating tumor DNA and assessing its role in prognosis and defining high-risk myeloma. I think it's definitely promising, but clearly not ready for prime time as of yet. We definitely need more prospective data and harmonization of the methodologies and the cutoffs before implementing it routinely in our staging systems.